Great, thank you very much. Thanks for the introduction and welcome everyone. I can't see you, but I'm delighted that you can join me. And I'm going to talk about primary angle closure glaucoma. I'm going to start off really just describing what glaucoma is and what this subtype is like, and then talk about how big a problem it is and really focus on the treatments, managements, and how things have changed a little bit in the last few years. So as I don't know what people's knowledge is, I'm just going to kind of go back to the basics as to what is glaucoma. And glaucoma is a progressive, irreversible, permanent damage to the optic nerve, which is the nerve that transmits signals, visual signals from the eye to the brain. As you can see it here. So when we're looking into the eye, we're looking through the pupil and we're looking at the nerve head on. So this is kind of sideways on. And the nerve contains nerve tissue, which is coming from the retina, but also the blood supply to the retina as well through the arteries and the veins. And then they spread out through the retina. And so when we're looking and examining, we're looking through the pupil. And what we're seeing is the optic nerve head. So that's head on. We're seeing where the nerve comes into the back of the eye. And when we're diagnosing glaucoma, we're distinguishing a damaged optic nerve due to glaucoma from a healthy nerve. This is a healthy optic nerve. So this has got, you can see the blood vessels coming out, and you've got what we call sort of plump, healthy tissue. This is the rim of the optic nerve. So that looks nice and healthy. And this is not so healthy. So this is what we typically see in glaucoma. So you can see that there's less of the pink area and more of this white area. And that's due to what's called cupping, which is bowing out of the optic nerve head. And you can see the blood vessels travel in a slightly more kind of indented way down through that. So that's optic nerves can be damaged due to other things, but this is typical glaucomatous optic nerve damage. And so how does that damage happen? So we have what's called aqueous humor, which is the fluid inside the eye, which is circulating. It's being made in what's called the ciliary body here. This is if you sort of turn the eye on its side and look from top down, front backwards, and then that fluid, just a slightly more enlarged one, so it's made here, and it comes out and it nourishes the lens, it travels around the iris, and it drains out through the trabecular meshwork and the angle. So that's an ongoing process. But if there's either an increased production of fluid or reduced outflow due to a blockage, then you'll get high pressure, and that will pressurize the optic nerve and cause damage. So when we talk about types of glaucoma, there's all sorts of different types, but the main types are primary glaucoma, and we classify that as to whether the drainage angle, which is where the trabecular meshwork is open or closed. And primary open angle glaucoma, which is the commonest type of glaucoma in our population here, is when the angle is open. So again, this is, imagine just sort of putting the eye on its back, slice through the cornea, and then this is the iris, the pupil, the lens, and the ciliary body. So the angle is this bit here, and this is what's called the trabecular meshwork, where the fluid drains out. So this is open and you can see it. This is primary angle closure glaucoma. This is when it's closed. So I don't know if you can see the difference. Trabecular meshwork structures there, you can see, you can't see them here because the iris is closing against the angle wall. So that is what we see. This is what's called an anterior segment OCT image, so optical coherence tomography, which gives us it's an imaging way of kind of taking a slice through the eye like this and focusing on the angle. And so this is the cornea here, this is the iris here, and this is the lens. And the angle is this bit here, and the trabecular meshwork is in here. And this is where the fluid drains out. And in this case, the iris is blocking that, so it's up against it, so it's a closed angle. So I think anterior segment OCT is a good way of sort of explaining things. We use it a lot now in diagnosis, but just to kind of show you some of the variations in the angle that we might see. So this is, again, this is a kind of cross section of the front of the eye, cornea there, iris, lens, angle, and it's called the angle because it is like an angle and you can measure it in degrees. And so this is a wide open angle. The angle there would be more than 40 degrees. Down here we've got a slightly narrower angle, so about 20 degrees, even narrower. So the iris is not quite up against the angle wall, but it is quite narrow, and this one's closed, so it's 0. Now it's important to talk about definitions because the management of angle closure glaucoma depends partly on the stage of the condition. And so we have these sort of different categories. So people can have what's called a narrow or occludable angle. And other terms for that are iridotrabecular contact, so contact between the iris and the trabecular meshwork, or a primary angle closure suspect. Now, in these eyes, the only abnormality is that the angle appears closed. The pressure is normal and there's no sign of glaucoma damage to the optic nerve. And I'll explain a little bit about what you're looking at here a bit later, but you can see here, this is closed. This is called gonioscopy. So we're looking kind of into the drainage angle with a lens mirror. And the next stage is what's called primary angle closure. So this would be an eye that's got a closed angle, and it may have another manifestation, which is further along what we would call the natural history of the condition. So it might have raised pressure. There may be areas of the iris that are actually stuck to the angle wall, but the pressure is, the optic nerve is healthy and the visual field is normal. So no sign of glaucoma. That's primary angle closure. And then primary angle closure glaucoma, when you've got the closed angle with the optic nerve damage and usually high pressure. So we assume this is the kind of natural sequence of events. There's a lot more people with this than this, and we'll come on to talk about the management of those different conditions. So if we talk really about glaucoma, because that's actually what matters, people who are getting visual field loss, who are the people at risk? So on a global scale, the prevalence, which is the number of people in the population at the same time with angle closure glaucoma, is much higher in Asia than it is in European or Caucasian populations. And this is data from surveys that are done in different parts of the world using standardized definitions that I've just shown you. And the darker red is where the prevalence is high. So in China, in Mongolia, and then there is a reasonably high prevalence in other parts of Asia. And the Eskimos in Greenland have a very high prevalence as well. That's quite important because Asia is quite a densely populated part of the world. So if you apply those percentages, so for example, 1% of everyone over 40 has primary angle closure glaucoma, and then you apply that to the actual numbers who live in those countries, you get very high numbers of absolute numbers of people who have glaucoma. And this is a more recent study which looks at the absolute numbers in Asia and projected for the next 20 to 30 years. So approximately 14 million people in Asia with primary angle closure glaucoma, compared to much lower amounts in Europe and Africa. It increases with age. So as people get older, because the lens in the eye is key in angle closure glaucoma, it usually gets bigger, and that causes a higher prevalence as people get older. In Asia, it is a more blinding disease than open angle glaucoma. So what we found in these surveys where you looked at how visually impaired people were when they were examined, it had far more people with one eye blind due to glaucoma in the primary angle closure group compared to the open angle group. So in that part of the world, it's a more blinding type of glaucoma. So how do we make the diagnosis? Well, we have various different sort of tools. So glaucoma itself, we make the diagnosis based on looking at the nerve, testing the visual field, which if you have glaucoma, you'll have done these tests. But to differentiate between open and closed glaucoma, we have to look at the drainage angle or try and gauge whether the angle is narrow or closed. And so we can do this in a number of ways. We can get an idea whether somebody might have angle closure by looking at the anterior chamber and the distance between the cornea and the lens. So this is the cornea, the clear bit here. Then you have the iris, and you can see we use what's called a slit beam, and we look at the distance between the two. So I'm just going to try and play this video, which is a patient who has quite a shallow anterior chamber, so not much space between the cornea and the iris and the lens. The angle is actually in here, but we can't see it on direct visualization. So I'll come on and show you how we do that. But that's what opticians would be doing to detect the condition. Would be going, this patient's got a shallow anterior chamber, they need to have further examination. So gonioscopy then is something that we as ophthalmologists do to really determine whether the angle is open or closed. And there's other things we look for in angles in patients with glaucoma. So if people have had an injury, they may have some abnormalities, or if they have abnormalities such as diabetes, that can impact on it. And so, as I say, you can't see the angle just by looking like this in our normal examination. And what we're trying to look at is this area here. So what we do is we put a lens on the eye, it's a contact lens, and it's got a mirror in it. And that allows us to look into the angle, kind of along the pupil line. And that's gonioscopy. It's not particularly pleasant having it done, but it doesn't take very long if someone's experienced. So if you imagine you're kind of standing on the pupil, just sort of here or here, and you're looking into the angle, that's the view you're getting. And this is a patient where we use this slit beam. We can't see the trabecular meshwork here. This is someone who's got a closed angle. And just on a bigger scale, so these are the areas of the trabecular meshwork which are draining the fluid. This is the functioning angle, and we can see it well in this picture because the angle is open. We cannot see it at all in this picture because the angle's closed by the iris getting in the way. And this is just an example of putting the lens on a patient to have a look at the angle. In recent years, imaging of the angle has come along, and that's a more pleasant experience for the patient because it doesn't require sticking a lens on the eye, and it gives us a view that can be seen on a screen and printed out, whereas when we're doing gonioscopy, it's just the observer who's looking at that can make an assessment. So this is a more objective view, basically, and it's non-contact. So you just put your chin on this. It's a bit like having a scan of the optic nerve, and it's very quick, and it could be done by technicians. And again, get nicer images these days. So all this sort of, I don't know if you can see this triangle here is the trabecular meshwork, and it's closed because the iris is stuck up against it. So we're using that a lot. We use it in our new patient clinics now to rule out angle closure for patients that are referred. So symptoms, do people have symptoms? Well, the majority of cases they don't. So it's like open angle glaucoma. It's often detected by your optician. If it's presenting late, then people will lose vision and have tunnel vision. Acute angle closure is a subtype that people know about because it presents acutely with pain in the eye, redness, blurred vision and seeing halos around lights, and feeling nauseous, even having a headache. It can be mistaken for a migraine, a stroke, all sorts of things. Generally, people are unwell when they develop this, and it's an emergency. It's an ophthalmic emergency. The reason they feel like this is because the angle has closed very suddenly, and there's been a build-up, very big build-up in pressure, and the pressure is very high. So if we go on to treatment options, then these vary depending on the different stages of what we would term primary angle closure disease. So let's go from the beginning. So these are the patients with narrow angle or primary angle closure suspects only. So they can either have no treatment or they can have a laser iridotomy, and I'm going to talk about these treatments in more detail. Those with primary angle closure, so a bit further down the line with high pressure, can have laser iridotomy, removal of the lens or cataract to open up the angle, or eye drops. And those with established glaucoma would tend to go more now for a primary lens or cataract extraction. But if patients don't want that, then a laser iridotomy plus or minus eye drops is another option, and a trabeculectomy, which is a drainage procedure which we do for open angle glaucoma as well. And so the reason we do these treatments is to try and open up the angle. It's a mechanical thing. We want to open it up. And the laser iridotomy and the lens or cataract extraction is a purely mechanical way of opening up the angle. So the laser iridotomy is using a laser with a contact lens to make a hole and burn a little hole in the iris here. And sometimes we use a combination of two lasers, and often in blue eyes, just one. And making a hole here stops fluid building up at the back. And so it has a shortcut out of towards the trabecular meshwork and flattens out the iris. This is what a laser iridotomy looks like in a patient who's had it. So you can see here, this is these are old scans, but the forward bowing is the cause of the closure, the forward bowing of the iris. The iridotomy, it flattens out a bit and the angle opens up a bit. Not a lot in this case, but a bit. And this patient has quite a big lens. They have quite a shallow anterior chamber, which is the distance between here and here. So actually then when they have the lens extracted, the angle widely opens up and the chamber deepens. So that's why lens extraction is so successful in opening up the drainage angle. It's just a bulky lens. You take it out, replace it with an artificial lens, which is just a flat single plane lens. So laser iridotomy, when lasers came in the 1980s, took over from using surgery to make a hole in the iris. This is just another example of it. Usually it should be up here or down here. I did my research in Mongolia, where this condition was quite prevalent. So we had portable lasers that we were taking to treat people with. It takes about 10 minutes to do. It's an outpatient procedure. It's not necessarily painful, but you are aware something's happening, and some people will find it more uncomfortable than others. And some people will require more laser and more energy to get through if they have darker irises. You can get bleeding, but it's usually temporary. Some people describe visual disturbances after laser treatment, such as seeing lines or a lot of trouble with overhead lights. Occasionally people get that. And some people may get high pressure and inflammation. So it's important to know about these potential risks and complications when we're deciding who needs treatment. So if we focus on the people who just have narrow angles only, what we used to do was offer all these people a laser iridotomy. But we knew that there's probably quite a lot of people with narrow angles who were never getting a problem and never developing angle closure, even untreated. So the question is, are we over-treating these patients of only whom a proportion will develop angle closure or glaucoma and potentially can get some of those complications? So there was 2 trials from Asia where they took people with these closed angles only, but no glaucoma, no high pressure. And one eye they treated with a laser iridotomy and the other eye they didn't. So it acted as a control. And they followed them up for 5 years. So this was the study in Singapore. And what they were looking for at 5 years is how many people had progressed from just having a closed angle to developing any other sign of angle closure or glaucoma. So high pressure, stuck down iris, or glaucoma. And they looked at this between the 2 eyes. They looked at a population that they selected aged 50 and above. And what they found, so progression was all those things I've talked about, was in the laser eyes, about 5% developed some sort of event compared with 10% of the control eye. So that would suggest that laser confers a benefit, but it would also suggest 10% is quite low for an event at 5 years. And these events can be quite mild, so slightly raised pressure, but area of more permanent closure. Very few actually developed an acute attack, which really is kind of what we're doing the laser for. The number needed to treat is a term that's used to say, well, how many people do we need to treat with the laser to prevent one event? And the number needed to treat was worked out as 20. So that's 20 people, of only whom one would have developed that event. So possibly over-treating it a bit. And again, just reiterating, we're talking about trying to prevent this stage, moving to this stage or this stage. The other big trial was done in China. It's called the ZAP study because of where it was set. And it was the same design, really. One eye laser, the other eye control, no sign of glaucoma or high pressure at baseline. And again, there was a benefit from the laser in that progression was less likely to happen in the laser group, but their number needed to treat was 44. So treat 44 to prevent one event. So that seems like over-treatment. And this trial actually had to be extended because what's called the event rate, so the likelihood something would happen, was so low. And again, very few people developed acute angle closure in the whole group. So this has resulted in a change in practice so that we don't treat everyone with a narrow angle with a laser iridotomy now. And we developed some guidelines for the Royal College of Ophthalmologists on the management of angle closure, which describes this in detail. And so what we're doing here is we're looking at the evidence from these randomized controlled trials to guide us in our management, because we don't want to be over-treating people, potentially causing symptoms or side effects if they don't need it. So what this summarized was that the incidence of sight-threatening angle closure disease in people with occludable drainage angles and no other abnormality is low, so less than 1 in 1,000 per year. And as a result, we advise not treating people with laser iridotomy unless they have additional risk factors for developing primarily acute angle closure, really is what we're concerned about. So what would those additional risk factors be? And if anyone's interested, there's a paper and editorial in Eye, which is the Journal of the Royal College of Ophthalmologists, which discusses this. So we use the term now PACS+, so a narrow angle plus a risk factor for angle closure. These might be patients who have diabetes, for example. They need their pupils dilated frequently to check for diabetic retinopathy, and dilating the pupil can, and in a narrow angle, can precipitate acute angle closure. People who are quite long-sighted, so they have quite small eyes, so they're more at risk of angle closure. So people who have a family history of acute angle closure, maybe if it's their only seeing eye, or if they live far away from emergency eye care. Some medications, such as anti-anxiety medication, and some of those sort of anticholinergic medication used for bladder conditions, for example, may be more at risk. Sometimes we just have to make a judgment call on it by looking at the eye. And as I said, people who live or work in remote areas. So then if we move on to the next stage, so people who've got more established signs of disease, high pressure or glaucoma. So again, another trial. So this was a trial that was actually started in the UK, but it was run in several different countries. And it was comparing, the thinking was, should we do laser iridotomy for these patients, or would we better just jumping straight in and taking the lens out? And this is just a video running down in the corner, which is a patient who had a clear lens extraction. So it's just showing you. So what we mean by clear lens extraction is the lens is not cloudy like it is in a cataract, which is our normal indication for removing the lens. So someone's got blurred vision. The lens is clear, but we're removing it to open up the drainage angle. So in this trial, patients who had either primary angle closure with quite a high pressure above 30, or primary angle closure glaucoma with a pressure in the 20s or above, were randomly allocated to either have clear lens extraction or the laser iridotomy, and they were followed up at 3 years. And I think the take-home message, there's quite a lot of outcomes for this. There's the primary outcome is the patient perception and their quality of life. And that was actually better in the lens extraction group. An easy way, I think, of explaining it is that the number or proportion of people who still needed eye drops to control the pressure after either intervention was significantly lower in the lens extraction group. So 60% of people in the lens extraction group required no medication to control their pressure at 3 years, whereas only 20% of the laser iridotomy group got away without using any eye drop medication. So that's, you've done the intervention, the pressure's still high, you need to get it down, so you put them on a drop, which is the same drops we'd use for open angle glaucoma. So the number of people dependent on medication, eye drops, to lower the pressure was significantly higher in those having an iridotomy, which suggests that the lens extraction's much more effective at opening the angle and bringing down the pressure. So we can now offer patients this intervention at diagnosis, but it's important to be aware of what the pros and cons are of each intervention when thinking about it and explaining it to someone who has this condition. So the advantages of the lens extraction is it seems to be more effective at lowering the pressure and stabilizing the angle closure disease. As I've said before, many of these patients are long-sighted, and they feel a benefit from having a new lens implant in, which doesn't leave them long-sighted, so their vision is better. Negative potential problems are, if you're young and you have this done, you can lose your near vision, what's called presbyopia. Now, people in the trial were age 50 and above, so it's less of an issue for them. We all develop presbyopia as we get older. But for young people, the quality of the vision may not be so good. There are risks of lens and cataract surgery. There can be inflammation, which can result in fluid at the back of the eye, clouding of the cornea. In very small eyes, you can get a condition called aqueous misdirection with very high pressure. And sometimes the new lens may not be able to be positioned if there's a tear in the lens bag, and retinal detachment. So there's a small risk of a reduction in vision with surgery. What about iridotomy? What are the pros and cons of that? Well, it avoids these risks of surgery. That's an advantage. And even though it wasn't quite so effective at lowering the pressure, patients who had the drops with the iridotomy, their pressure was lower, and there was no sign in the trial that they did worse in the long term in terms of developing glaucoma or visual field loss related to glaucoma. So it's just they require more treatment. And there's still an option of doing the laser iridotomy and then doing the lens extraction later if that works better. So those are the advantages. Disadvantages, as I said, you're more likely to need drops to control the pressure if the pressure was high before the intervention, and the pressure may not come down as well, and just those other potential problems with laser iridotomy that I mentioned before. So again, this is just a snapshot of the guidelines and our resulting change in practice, which previously we would have offered all patients presenting with any form of angle closure a laser iridotomy, and then we would have thought about either removing the lens or putting them on drops. If that didn't work, we will now offer people clear lens extraction if they fall into the group that I've said already, so they've got established angle closure disease. But the emphasis should be on offer and have a detailed discussion about the pros and cons so that the patient can make a decision themselves. And then we come on to an acute angle closure crisis, which is when you get the sudden rise in pressure. This is an ophthalmic emergency. If the pressure is not brought down, then people can go blind over the course of a few days, as it's very high pressure and damage to the optic nerve. So what we tend to do here, patients come to an eye emergency department. They're given eye drops and injections to bring the pressure down and do what's called break the attack. So make them feel more comfortable, clear the cornea. And once that's done, we would do laser iridotomies in both eyes. And that's really important because the risk of an attack happening, so typically this would happen in one eye, but the risk of it happening in the other eye is about 50%. So we do laser iridotomy really to protect the other eye and to prevent a recurrent attack in the affected eye. Sometimes it's not possible to do a laser iridotomy, the attack is not broken, so we use other types of laser. And if people get recurrent attacks despite laser iridotomies, we would take the lens out at that stage. Or if the pressure stays up and the angle is closed, we take the lens or cataract out. And sometimes this can be precipitated by having quite a significant cataract. So the lens has swollen and is closing off the angle. So that's very important that that's managed and that people are admitted to hospital if they need to be, to make sure the pressure comes down in the eye. But it's not common, and it's not the common presentation of primary angle closure or angle closure glaucoma. So that's the end of my talk, and I hope that was helpful, and I assume there's some way that people can ask questions in the chat or something.
Great, thank you ever so much, Winnie. That was really good. I'm Liz, and I'm sorry that I wasn't here at the beginning. I was having technical problems, so huge thank you to Robin and for Winnie for making the start without me. So if you do have questions, please pop them in the chat. Sorry, into the Q&A box. If you put questions in the Q&A box and then your general comments into the chat. We do have one question in there already, Winnie. It's about the relationship between primary open angle glaucoma and primary angle closure glaucoma. The question is, if diagnosed with primary open angle glaucoma, is it possible to also develop primary angle closure glaucoma?
So if you've already got open angle glaucoma, that is usually the primary mechanism. Now there's probably a small number of people who might have a narrow or closed angle or develop that over time with glaucoma, but I don't think it's, I think having the two mechanisms of glaucoma is very unlikely.
Great, thank you. So please do pop questions into the question. So there's another question asking how people actually know which type of glaucoma they have, because very often we actually find that people don't know that. What should they do if they don't know which type they have?
Well, they should be able to ask their specialist. So if they're under an ophthalmology department, that should have been, a diagnosis should have been made when they were diagnosed with glaucoma. So when they came to the department, they would have, the initial testing would have included an examination of the angle. Now that might have been using anterior segment imaging, which I showed pictures of, or it might be gonioscopy, putting the lens on. But that's what we would do for all new patients who were referred to us with suspected glaucoma. And so we would make that diagnosis. So you can always, if you don't know, you can ask, but generally the treatments are different. So you'd expect to know if you have angle closure glaucoma, because the treatment for open angle glaucoma, the primary treatment would either be eye drops or a different type of laser called a selective laser trabeculoplasty.
Great, thank you. And linked to that point you just made about the treatments being different, there's a question here about the Hydrus micro shunt. Is that only used for primary open angle glaucoma, or is it also used for PACG?
So the Hydrus micro stent, if people don't know what it is an operation that's usually combined with cataract surgery. And at the time after taking the cataract out, you put that gonioscopy lens on and you stick a little stent in the angle to try and get it draining better. So for two reasons, I'd say that that Hydrus microstent is not indicated. One is that taking the lens out or cataract is very effective already. So there isn't really any indication to do something additional. And when I say effective, I mean bringing the pressure down. And the second is that we rely on data from research or trials of the stent, and those have been done in open angle glaucoma. So generally speaking, that would be what it's licensed for, is open angle glaucoma. it's not to say you can't use it, but as I say, as you could see from that data from the Eagle trial, the success of removing a cataract in someone with angle closure glaucoma is quite high in terms of controlling the pressure. So I wouldn't put a microstent in.
Okay. We've had a comment here from someone who had laser iridotomy in both eyes quite recently in December, and they've got a follow-up appointment coming up in April. They didn't actually ask any particular question to that, but I wonder what people can expect in terms of recovery and follow-up appointments.
Yeah. So recovery is quite quick, you know, over a couple of days that the eye should feel normal and you shouldn't have any ill effects. The purpose of the follow-up appointment is firstly to check that you haven't had any problems, that the pressure is okay, that the iridotomy is, we use the term patent, that it's a hole still, because sometimes it isn't possible to get all the way through and needs more treatment, that it's large enough. And also we would repeat the gonioscopy to look at the angle to see whether it has made a difference to the configuration and opened up the angle. So it would be a pressure check that you're okay, and look at the iridotomy and probably do gonioscopy or an anterior segment imaging method to look at the angle.
Okay, great, thank you. And a couple of questions here mentioning normal tension glaucoma and whether that's open or closed angle.
So normal tension glaucoma is usually a subtype of open angle glaucoma. Now, as I said before, some people might have when they describe normal tension glaucoma, it's having glaucoma with pressure in the normal range. So some people may have an occludable or a narrow angle as well, and that's where you can sometimes get this kind of mixed mechanism. It's not that common. The question also says that iridotomy is permanent. Yes, they are. They don't close. You know, the question is whether they're big enough. You know, if it's too small, it won't do the job, but they don't kind of grow over, which is something that people are concerned about.
Right. Does PACG lead to blindness if pressures stay high? How common is that? Obviously, glaucoma can lead to sight loss, even blindness, but how common is it in PACG for it to actually lead to blindness if the pressures stay high?
So, in our population here in the UK, most glaucoma is picked up early by opticians, so we don't get that much presentation of late glaucoma, and it's unusual to see late presentation of primary angle closure glaucoma. In Asia, it's slightly different. So you'll have different populations who have different access to healthcare, and about twice the number of people in Asia compared to Caucasians will develop blindness in one eye. So in that part of the world, probably because the pressure with good going angle closure glaucoma, the pressure can be very high. The higher the pressure, the more rapid the damage to the optic nerve. Generally in this country, if it's been picked up and detected, you shouldn't lose vision. But that's why in, for example, acute angle closure, where the pressure can be very high, it can be 60 or 70. If that's not treated or not picked up, then people can lose vision quite rapidly with that.
Okay, and a question here about anticholinergics and what the potential risks or side effects are with those.
Well, they can affect the pupil dilation. They can affect the nerve to the pupil. So they can mean that the pupil is slightly more dilated. And so if someone has a narrow angle and they are on that medication, they might be more at risk of developing acute angle closure. And so they fall into the category of benefiting from a laser iridotomy, which will hopefully open up the angle. Once they've had the iridotomy, laser iridotomy is very effective at preventing acute angle closure. And we know that from the fact that if you treat the fellow eye of someone with acute angle closure, their chances of developing it are low in that eye. So once you've had the iridotomy, then you can use the anticholinergic. The risks are much lower. I don't know exactly, but it's safe to at least try taking that medication if you've had an iridotomy.
Thank you. And a follow-up question to the one we had earlier about follow-up appointments, asking if the hospital discharges someone after a follow-up appointment, how will that person know in the future if the laser iridotomy is still actually functioning, doing its job?
So as I've said before, the iridotomy won't close. The angles that can narrow a bit more as the lens gets bigger, but generally we wouldn't intervene for that unless the pressure went up or you develop glaucoma. So that is something that can be monitored by an optician, a community optician who picks up glaucoma. So that's why we can now discharge patients who've had a laser iridotomy for narrow angles, because they don't have glaucoma, and their chances aren't very high of developing glaucoma because they've had the iridotomy at an early stage. So I would advise having maybe 18 monthly checks at the optician to look for the typical signs of glaucoma, high pressure, visual field loss, or optic nerve damage. And then those are the only indications for doing further intervention. But normally further laser is not required. It would be treatment such as eye drops or surgery.
Thank you. And we've got a question here about when medications are ill-advised for people with angle closure glaucoma. Should people with primary open angle glaucoma also avoid those medications, or are they generally safe for people with primary?
So they don't need to avoid them.
Okay, great. That's so we've got another question about trabeculectomy and when that would be an appropriate treatment. At what point would you be suggesting a trab?
So if we look at the trial data from the EAGLE study, which looked at the lens surgery, that looked at people with moderate or early visual field loss. So generally speaking, people would intervene with a lens extraction first. And I personally would say that if people have very advanced glaucoma damage on the visual field, so like tunnel vision, or the drainage angle is very permanently closed, so those areas are stuck down all the way around, that would be, myself as a practicing ophthalmologist, I would probably go for trabeculectomy in those cases. And that's not something that everybody would do, but the other indication I think would be if you have someone quite young. I once had a patient in their 30s presenting with quite advanced glaucoma in terms of the amount of visual field loss, angle closure glaucoma. And so someone like that, their vision's not going to be great if they have a clear lens extraction. They're going to lose their near vision. And I felt that they weren't going to benefit from opening up the angle, because the more advanced the glaucoma damage, the more likely the drainage angle is permanently damaged. So even mechanically opening it up may not mean that the fluid passes out through it. So I think there's a small number of people with angle closure glaucoma who might benefit from a trabeculectomy, but they tend to be people who've got quite advanced disease, which is quite different from open angle glaucoma, where it would be our kind of primary surgery of choice.
Great, thank you. If anyone has any more questions, we do have a few minutes left, so please do pop them in the question and answer session. We did have a question sent in by email in advance by someone who couldn't come this evening, asking about angle closure glaucoma in children. Can you tell us anything about that and how the treatment in children might differ from adults? You've already talked about this a little bit with lens extraction, but anything more to add on that?
Yeah, I mean, it's very rare. It's very rare because the underlying kind of pivotal cause of angle closure is the lens, actually. And it's the size of the lens in the eye, and it's growing. So there are some conditions where people have abnormalities of the lens. So they might have a more spherical lens, or they may have a lens that moves and is dislocated. A condition called Marfan syndrome, where people, the lens support system is loose, so the lens can move forward and backwards, and that can close the angle. So those are what we would probably call secondary angle closure. And generally, again, it's all around the lens. So it's removing the lens, putting an artificial lens in. But it's not common at all in children.
Great, thank you. Okay, Robin, are there any comments in the chat that I might have missed, or any questions that I've missed?
There is one question that has come in on Facebook, and that is, what is the role of pilocarpine in the treatment of angle closure glaucoma?
So pilocarpine is used as part of the first line treatment of acute angle closure, and that's to try and what pilocarpine does is it makes the pupil smaller, and by doing that, it's pulling the iris away from the angle wall and trying to open it up. So we give it to people who come into our A&E department who've got an acute attack. That's the main indication for it. There is a very small number of people who may not want to have a lens extraction. So they may be some people can get a symptomatic kind of angle closure when their pupil dilates. For example, if they go into a dark theatre or a cinema, the pupil dilates, they get halos and they get pressure rise. Now, I would suggest those people have a lens extraction. That will sort them out. Some people don't want that, and that's fair enough. So pilocarpine potentially for that group, but it's not something that should replace an iridostomy or a lens extraction if they're indicated, generally speaking. So not as commonly used as it used to be.
Okay, we have just had another question come in. I'm just trying to read it. Bear with me. Would there be any problem with having diplopia surgery if you've got narrow angles?
So I think by that it means sort of what we call squint surgery. So that's moving the muscles around if people have double vision. So that's all done on the outside of the eye. So no, there shouldn't be any problem.
Okay. Great. Robin, any others on Facebook or anything?
No, I think that's all of them that have been covered. That's brilliant.
Okay. Well, oh, we've just got another one in. Hang on. Right, so we've got a question here about blood pressure and eye pressure, and whether high blood pressure can have an impact on eye pressure.
There's not really known to be a direct link. So a lot of people have hypertension that they're treated for. We don't think there's a direct link there. If somebody had very, very high blood pressure, they might have high eye pressure, but it's not something that we see that commonly. But there is evidence now from a big population survey in the UK, in Norfolk, suggesting that people who are on blood pressure medication or their blood pressure is lower may have lower intraocular pressure. Don't quite know how they're linked, but there isn't a direct link, really, I think.
Okay, brilliant. Thank you very much. That was really interesting, and I hope useful for everyone as well. Certainly very informative. So thank you very much for all of that. So we have just had one other question, which we will take, and then we'll call it a day. And this is about preventative treatments. Is there any preventative treatment for angle closure that people should be aware of?
So I presume that's kind of referring to sort of lifestyle factors and things. Not really, because it's a kind of mechanical, it's a mechanism, it's something that you can see, and you can't really alter that. So the laser iridotomy can have a small benefit in doing that by opening up the angle and preventing the next stage. But in terms of preventing that anatomy or configuration, I'm not aware of anything that makes a difference to that mechanism. There is stuff coming through now suggesting things like exercise, maybe yoga, are good for reducing intraocular pressure, but that's slightly different. That's more in the open angle group.
Mm-hmm. Great, thank you ever so much. That was really informative. So if you do have any questions that we haven't answered, or you think of something afterwards, please do give our helpline a call or send them an email. I'll give you those details in a moment. Robin, could you launch the second poll, please? So this is just another quick poll to ask how much you feel you've learned this evening, just to give us some feedback. Whilst you're doing that, those helpline details, you can call 01233 648170. That's 01233 648170, or email helpline@glaucoma.uk. And that's open Monday to Friday, 9:30 to 5 p.m. And they're very happy to answer any questions you've got about glaucoma or related conditions. Our next digital glaucoma support group is on the 15th of March, and it's looking at research into home testing and monitoring of glaucoma. That again will be at 7 p.m. And the following one on the 12th of April is with Anthony King, who's Glaucoma UK's chair, as well as being professor at Nottingham University. And that's a chance for you to ask any questions you have about surgery or laser. So please do join us then for either of those sessions if you can. When this webinar ends, we will launch a feedback survey. Please do fill that in. We do look at them, we do take account of your feedback, and we want to make sure that we make these sessions as good as possible. So please do spend a few minutes filling that in. Even if you've done it before, it's still useful. Again, Winnie, thank you ever so much for your talk. Really informative. We really appreciate your time. And thank you everyone for joining us. And that's all for today. So until next time, thank you all and goodbye.